All right, ladies and gentlemen, I have 12:03. Why don't we get started? Again, for those of you who've just joined, my name is Kenley Money. I'm with the Arkansas Center for Health Improvement, and we are the group that hosts and runs the Arkansas All-Payer Claims Database. Today is our first webinar for our data users group, and we are so excited because our reach is much wider using a webinar, and this is a platform we intend to use ongoing. Right now, we have somewhere in the neighborhood of 34 people on. I know we have data requesters and analysts and those who are just interested, so I hope there's a little bit of everything for everyone. My trusty project manager, Kathy Hart, runs the slides. I'm going to ask her to move to the next slide, please. The agenda today, the welcome, which we're in, and the topics we're going to cover, you can see here there are 5. The APCD, Unique ID Collision Reduction Methodology, Medicare Advantage Claims Identification, Patient Attribution Methodology, Qualified Health Plans by Income Strata Identification, and then the latest release notes and data tips. Now this is a lot. There are 5 bullets here with questions and discussion. Our goal is to get through it all, but it is entirely possible that we won't. So we'll get as far as we can so that even whatever we cover will be valuable to the participants on the phone. As we move forward and talk about these, we have several slides on the first one, certainly, and on the remaining ones. And what we'd like to do is to get through the slides and then open it up for questions. And you can raise your hand and we'll unmute you for the question. And if it may be that in the middle or as we go through the slides on each subject, a question seems relevant at the time, you can raise your hand, but we hope to have all the questions at the end. So take notes, be ready to take notes. A little more housekeeping, I almost forgot. At the end of this, after questions and discussion, we will send out a survey. Actually, it'll probably be about mid-afternoon. I hope you take the time to fill out the survey. We'll have lots of questions about how this was for you, what would make it better, how the different subjects were, and we will move forward. Okay, Kathy, will you go to the next? There will be 3 speakers today. There's me, and then our Assistant Director of Analytics, Nicole Sanders, and our Director of Analytics, Mike Motley. Let's move on. Great, we are excited to have us all there. All right, we're going to begin. We're going to turn it over to Nicole to talk about APCD Unique ID Collision Reduction Methodology. I expect that as we discuss this, you will go, oh yeah, I've seen this in the data, and this will be very, very helpful. So Nicole, I'm going to turn it over to you. Are you unmuted? Oh, I cannot hear you yet. Oh yeah.
Wait, what about now? Okay.
Yes.
All right. So I'm seeing if I'm moving the mouse now.
Yes.
I think. Okay. Excellent. So let me first give you guys a little refresher. For those of you who use the data, you realize that there are at least, well, there's 2 identifiers that you can use in the APCD claims data, especially. One is the member ID, which is used to link enrollment information from claims information, or link enrollment information to claims information within the same payer. So it's actually on both the member and the enrollment records and the claims table. We also have the APCD Unique ID, or hash ID, which is a hashed value that represents a concatenated member last name and date of birth. If you combine this with gender, you have a pretty good proxy for identifying a single individual. But there's 2 things you need to be aware of. One is that for claims data, the hash ID is only on the enrollment table. And you have to use the hash ID to link between payers and across, or between payers and across claims and non-claims-based data. So what I'm presenting today, I hope will help users in general be able to determine a close approximation of the number of individuals in a study population. And as we go through this, I think the need for an approximation will become more clear. So, because the hash ID is just last name and date of birth concatenated, there are situations where different members can have the same hash ID. And those are what we call collisions. Let me see. This also can include, we do concatenate the hash ID with gender to reduce collisions, but that's still not enough. You're still going to have collisions, which you can see here. We have an example of a single hash concatenated with gender. So this is supposedly one individual, but when you look at the records, we have 10 different member records, which are submitted from 4 different entities with 7 different member IDs. So how many different individuals are there really? Are there 7? Is there just 1? One of the ways you can do this is, or determine this, is you can look at enrollment data, like enrollment spans, but that's still, you still wouldn't be able to tell if perhaps a person had different coverage or a different coverage type within the same payer. Let me show you, if you add more information, you can kind of get a better idea of how many individuals you have. So for example, it is most likely that this is a single individual based on, if you look at group name, Pike County, I would expect that this group is a very small group. So the likelihood that you have a single person here with multiple member IDs is pretty high. If you look at, and also let me point out that there's contiguous enrollment dates here too. This next group of records, you at least have the same member ID. So it's pretty safe to say that along with the group name, same member ID, contiguous enrollment records, that this is a single individual. And finally, this group of records is also most likely a single individual, even though we again have 2 different member IDs. They're within the same submitting entity. And again, I'm not sure, but the Southern Rail Company is probably a relatively small group. So the main point that I want to make with those examples is we've just come up with 3 most likely different, or 3 different counts of individuals. We have 1 hash ID gender combination, but we know that's not quite right. We have a number, 7 different member IDs for different payers. That still seems kind of high for 1 hash ID. And if we actually go in and look at the data, we can see that there's likely only 3 individuals. But we had to go deep into the data. And that doesn't actually help us if we're trying to link across, across claims data and non-claims data. So I suspect that you guys are wondering what or how serious is this collision problem? Well, Dr. Connell Lewis has found, or with ACHI, has found that through modeling, the collision rate can be around 3.5% of individuals, and it decreases with smaller analytic data set size. Dr. Lewis found that through modeling, the collision influencers, there's several. She found that, you know, we all know that twins, that makes sense that twins would be an issue. And while we can concatenate gender to hash ID, there's still going to be identical twins. And we also know that there can be very common last names, and that these common last names actually change over time. There's also common dates of birth within groups or years. And finally, something that we can't actually include in the model is data quality errors, because every submitting entity is different. We can't model what each of their different data issues are because we can't necessarily predict what those would be. Oops, let me go to the next slide. Okay, hang on. Okay, I think this slide's pretty cool. I really do. I think it's really cool because I love data and there's interesting patterns that you can see here. But these are the factors that Kana used, or Dr. Lewis used, to model the expected rate of collisions. You can see that, interestingly, in 2016, for example, and most likely for the last 20 years, we are having a lot of babies delivered during the week and not so much on the weekends. This is most likely due because a lot more births are being scheduled and not just happening when they're going to happen. We also see that there's more births occurring in August versus April or February. And also, there was a higher number of births in Arkansas around 2007. And finally, the last names play a role. And you can see that in the last 25 years, while the top 3 names, most prevalent names, are the same, they've changed. Their rate has changed. And now Davis is more prevalent than Jones. Also, something to note is, for example, Hispanic last names have started to increase in prevalence. I believe Garcia was 267th on the list, and in 1990, and now it is maybe the 21st. So Dr. Lewis took all of these factors and put them together and did her modeling that she's so great at, and got an expected rate of non-unique hash ID gender pairs, which is a collision, of 3.5% for a population or a sample of about 40,000 people. And it's interesting to note that you can see as the size of the sample or population goes down, the rate of expected collisions also decreases. But I think it's important to note that this model is based on a single data set from a single source. So if you're trying to link across multiple sources, it could be that in the claims, in the population you're studying from the claims, they have certain hash ID gender combinations that are colliding. But if you're trying to link it to another non-claims data source, they could have a whole other different group of hash ID gender combinations that are, excuse me, that are colliding. So the problem can become exponential. So okay, so you can manage this in a couple of ways. First of all, if your analytic data set is going to be very specialized, it's going to be very if it's a rare disease, a certain drug, or maybe it's within a certain payer type like pharmacy, then you probably don't have to worry about collisions because A, the size of the analytic data set is going to be small, and B, you're not going to be linking across data sources. I still recommend looking at whatever collisions you might have to decide whether or not you need to use like the hash ID gender combination or the member ID to count individuals. It could be that if you're working with a very large analytic data set that is focused on maybe common conditions or maybe all the medical claims for 1 year, then it's likely that you can go ahead and drop all of the colliding, all of the records with colliding hash ID gender combinations. But before you do that, I recommend using this collision reduction methodology or a similar methodology to preserve as many records or members that you can. So what we do is we actually develop 2 identifiers that I've been hinting at this whole time. One is based on the member ID, which we call the SEID, and it is a concatenation of submitting entity and the member ID. You can make this ID in any of the claims data, obviously. You just have to use sorry, I just had a visitor. You just have to use the appropriate fields in each data set. And then you can use, then we also create what we call our study ID, which is the hash ID and gender combination. And I want to reiterate that this variable can only be developed from the member table in the claims-based data set. And I don't want to forget to tell you guys anything important. So I do want to point out that a single study ID can have anywhere between 1 to 4 SEIDs. We obviously expect most of them to have 1 or 2, much less to have 3 or 4. And again, regardless of the size of your data set, I always recommend that you look at the collisions just to see if there's anything that stands out, any kind of pattern that stands out. I actually realized that in one of our data sets, we were getting a lot of EBD TPA claims, so from the third-party administrator, but not all of the EBD claims. So we needed to be sure that we weren't including both claim set. So this is an example of the different types of collisions you can see. We have 2 study IDs in this example. And this first one, it has an SEID from Blue Cross Blue Shield and one from EBD. So is this the same person? It could be. When you look, it could be somebody that has different periods of enrollment, and it's not overlapping enrollment. But again, you're going to want to look and make sure if it's worth if you want to drop it, if it's going to have a big impact in your study. If you're doing a study that has looking at overall healthcare experience for a year, that's when it becomes important to check some of these things. This particular study ID is associated with 4 different SEIDs. These first 3 could be different types of coverage. For example, this could be medical coverage and pharmacy coverage. Or maybe this is medical coverage and pharmacy coverage. You can't just tell by looking at the submitting entity IDs. In order to, well, let me say this. You may want to just drop all of this study ID because there's so many different records or SEIDs. But if you use a collision reduction method, you can parse the study ID, SEID combinations before you drop them so that you won't lose all your records. But to do this, we divide the enrollment records into different types of coverage. We have the commercial coverage, which excludes Medicare Advantage plans. Then we look at the Medicare Advantage plans, Medicaid, and then dental and pharmacy plans together. We actually do this in this order too, because Medicaid and dental and pharmacy plans tend to have collisions that we don't want to lose necessarily. When you're as you're dividing these types of coverage, you're going to want to create your SED within the coverage type. And you do that by assigning the study ID to each SEID based on the most recent record using enrollment date. So in this example, had we not created those study IDs separately, we would have dropped all of BF. But instead, if we run the collision reduction methodology on commercial first, we might decide to drop these SEIDs. And then when we run it on Medicaid, we would still just have this one. We wouldn't lose Medicaid. So I hope that helps. This is my first time not giving this talk in front of people with a whiteboard and drawing things out, so it was a little bit of a challenge. And I'd be happy to answer any questions at the appropriate time.
Hey, Nicole, this is Kenley. Can you hear me? All right, we probably will open up to questions. For the group, I wanted to provide a little bit of context in that the Arkansas APCD does not get personal identifiers. So we've had to come up with this process to, as Nicole explained, figure out which records are associated with an individual and which, not to re-identify, but to know which ones to group together. And the hash ID plus that gender is the proxy for the full PII that we get. Now, Nicole, you use this a lot, right? You use this methodology. How successful have you been with it?
I use this methodology on every single study. Like I said, in the beginning when this methodology was being developed, we didn't realize that Medicaid had so many IDs that where you would have an old Medicaid ID and a new Medicaid ID, the same person. So that was one of the reasons that we use this. We also use this, and it became really important when we were looking at members that were covered on Arkansas Works, and or the private option, and we wanted to see where they might have gone, what other plans they might have gone to. If you do commercial in that scenario and Medicaid together, Medicaid has enrollment records for everybody that is on Arkansas Works, but they do not have claims. So it's really important in that situation to keep only the commercial, only the study IDs that are associated with the commercial payers, and not those created with Medicaid when you're counting individuals.
Mm-hmm. That's a subject all in itself right there.
It really is.
So in your experience, Nicole, how often do you think you have to get into collision methodology? How often do you just find that you can disregard the collisions in your study sets?
It is so highly dependent on your study, the size of your study. Like I was saying, and you know, ACHI does a lot of different types of studies. So even when we do a small sample or a very specific group, for instance, we looked at naloxone use over the last 5 years. You obviously have a very small number of individuals that were prescribed naloxone like 5 years ago, but that number is increasing. However, even now, the number is so small that you don't have to worry about collision reduction. You can just go with what you have, and sometimes that's all you want to do. If you have only 1,000 records, you're going to want to keep everything you have.
Mm-hmm. Does anybody have any questions? You want to raise your hand in chat? Screen went away. Okay. Well, we're going to move to the next slide, to the next subject, and do record your questions. We can always get them at the end. The next one is Medicare Advantage claims identification. We have, and Nicole can speak to this, but we have at ACHI on several occasions needed to identify the Medicare Advantage population, not just for collision reduction, but for other things. And we've gotten some requests and questions from data requesters about how to identify the Medicare Advantage people so that you can segment and analyze the claims. So if you'll go to the next slide, Kathy. Oh, okay. So disregard the red. I shouldn't have had that. But look at the second bullet where it says ME003 equals, and you'll see a whole bunch of values. This field, ME003, is insurance product type. And if it's on the member record, so if you want to find your Medicare Advantage people, then go select everybody with ME003 equal to those values. And then once you have those people, then you can take the SEID, which is the concatenated it's the concatenated carrier SEID and member ID, and then you can go into your claims data and pull them out. And so that's how we identify Medicare Advantage data. That's a small thing. I don't have any more slides on this. You'll get these slides after, but this is a best practice that Nicole and her team have established. Next slide, please. Okay. Mr. Mike Motley, are you available?
Yes, I am. Can you hear me?
Yes, the next section is about patient to provider attribution methodology, and this is a project that Mike and Nicole worked on. Mike, you can please describe.
Sure. Good afternoon, everybody. So this slide is titled Patient to Provider Attribution Methodology. For a little bit of background, patient attribution, it says here is a process of assigning patients to a single provider based on their utilization of primary care services. This methodology is one that's based on several that have come up through the past decade, really around population-based, value-based payment models. There are other reasons you would want to do patient attribution, but essentially you're saying which patients would be attributed to which providers. This is used to establish a denominator of patients for which a provider is deemed responsible. So for quality measurement, value-based payment models, as I said, et cetera. This is something our center most recently has done for Community Health Centers of Arkansas. They are the federally qualified health centers throughout the state. There's about 120 of them, 120 clinics that are under the umbrella of about 12 administrative entities. So I'll get more into how we applied this for those populations in just a bit. If you go out there online, you can find where the Center for Medicare and Medicaid Services has developed and published attribution methods for their Medicare populations and different programs. Locally, Arkansas Medicaid for their patient-centered medical home program and Arkansas Blue Cross Blue Shield have developed some tailored attribution methods, and they do publish those in pretty good detail out there in the provider manuals associated with those value-based payment programs. Next slide. So the method that we adapted, borrowing from local and national methods, is selecting individual providers based on their national provider identifier number, and that is in the claims data, medical claims data, and pharmacy data. So we look at any claims associated with those NPI numbers. Those are extracted to determine unique patients that have received any primary care services from the chosen providers within a measurement period. For our purposes, it's usually a calendar year. Once we determine which patients had any contact, then we look at, among those, which patients received a plurality of their primary care services from a given provider. Those are then deemed attributed to that provider. So plurality meaning they got more primary care services delivered by one provider than any others. Next slide. So a little more on how we did this for Community Health Centers of Arkansas. We do an annual quality assessment for them. We look at HEDIS quality measures. We look at a couple metrics across hospital utilization. And we look in general at what proportion of their patients receive more care from them, primary care from them than other providers. So the first thing we did was we confirmed which providers and their associated NPI numbers were associated with which community health centers administrative entities. So we did that by a couple ways, but we found a lot of those online, and we worked with the administrative leads, 12 of them, and CHCA leadership overall to have them review for that measurement year the list of providers and their NPI numbers. In some cases, they would add some. In some cases, they would say that that person did provide some care for our patients, but only for a month out of the year, and we would take them out of the list. So for each, go back to the Venn diagrams, Kathy. There we go. So for each administrative site, you'd end up with a list of providers and NPI numbers. So we would extract all the claims associated with those NPI numbers for unique individuals that received any evaluation and management services. So we identify those through CPT codes, and then well care visits via ICD-9 or ICD-10 codes. And once you do that, you can determine by account which unique patients receive a plurality of those services from the providers of interest during that measurement period. So the Venn diagram, the overall darker blue, this is patients receiving any primary care services from a provider, or in our case, a group of providers. We rolled up to the administrative site level, so you might have 10 clinics under one, and another entity might have 15. In the kind of teal color, that is the proportion that we would deem attributed or receiving the plurality of their primary care services from that provider. We then took those individuals that we deemed attributed, and that forms the denominator for all of the quality metrics that we looked at. It's kind of a question of, we think these are the patients that you treat that come to you more than anyone else, so therefore you should be responsible. And that worked out as something that was acceptable to all their administrative sites, and I think they've benefited from this. With the case of community health centers, we were lucky in that we had reporting that they are required to do, and it's called the Uniform Data System, but they're required, because they receive federal funding, to report the number of unique patients they see in a year. And so that was our contextual check against our dark blue circle here. So we would call these the individuals that had at least one touch of any care from these providers. And we saw that across the 12 entities, we were getting pretty close to what they said was their number of overall unique patients. So we were lucky to have that contextual check. I think the gold standard in patient attribution has been described by some national groups as when a patient says this is my provider, and the provider says, yes, that's my patient, I take care of them. But obviously from a analytic or claims perspective, that's not always available. Locally, we have patient-centered medical home programs where each payer has a roster of attributed patients per provider, and they share that with them on a quarterly basis. So if there's a situation where you knew exactly what that attribution was, then obviously you could use that. But for these purposes, we think this is a pretty close approximation of what it would look like for community health centers of Arkansas. I'll take any questions on that.
That was very interesting. Thank you, Mike.
Thanks.
All right, continue to gather your questions. We'll move to the next bullet. Oh, we're making progress. Qualified health plans by income strata identification. Let's go to the next slide. I just have a couple of slides on this. So on the Arkansas APCD data, as Nicole mentioned earlier, we have the Arkansas Works data and the qualified health plans. And on the member record, we carry the HIOS ID, ME992, you can see on this slide. And within the HIOS ID, there is a variant, the last two digits, which is an FPL distinction, and it can be very useful in analytics depending on the questions that you're trying to answer. You can see in the blue box the official definition of HIOS ID, a 16-byte identifier. I won't read this to you, you can look at that. But do note the examples there. These are HIOS IDs that came straight from our data. The first 14 bytes have meaning about the plan, and the last 2 bytes have meaning about the FPL. So let's go to the next slide. This is a handy chart to keep at the ready when using Arkansas data. These are the variant or modifier descriptions, 00 through 06, and their FPL designations. And then the last two we spend a lot of time on is looking at the 32s and 36s. In fact, that's slang in our office, the 32s and the 36s, and because those are the individuals on the Arkansas Works plan and their FPL designations. So when you are considering acquiring Arkansas APCD data, do ponder whether you should include the HIOS ID ME992. It can be very, very valuable to your research and analytics. So that's just a quick thing about that. So let's move forward. And the last thing on our agenda here is latest release information. So this is on our website, but we thought we'd bring it forth here. We have moved into a quarterly submission process. And so we've just started that. So the data will start coming a little faster. Let's go to the next slide. Right now, we have data in the Arkansas APCD through September 30. And our next update in the next month or two will have all of 2019. So that should be September 30, 2019, apologies. So that would be great if it were in the future. The infographic is at this link here. And Kathy, can you click that? Will that work? Let's see if that'll work. Nope. Okay, let's cancel. Okay, anyway, there's an infographic out on our website that highlights, that includes everything that is in the current data that is available for purchase right now. Let's go to the next slide. Oh, okay. Our apologies. We have been having some network issues, and oh, good, yeah. And so Right now, the data that we have, you can see we have the claims data, and we also have non-claims data. You heard Nicole use that term from time to time. Non-claims data are other types of data that also can be linked to the APCD using the hash ID and the gender. And so we have data from our health department, including vital statistics data, hospital discharge data, emergency department data, what you can see there, and the date range, the coverage there. And we have Arkansas medical marijuana card holders, and you can see the date range there. All of these dates, except for the card holders, begin on January 1st, 2013. Let's go to the next slide. Now, when you start to acquire, if you've acquired data in the recent past or you're going to acquire data, you should know that depending on the quality of data submitted by the carriers, we may or may not include them. And that's important to note if you're doing population-based studies. If we have found, especially in the beginning when we first produced the data, we found that some carriers' data was compromised, so we had to exclude it or tell the data requesters not, if they received some of it, not to use it because its quality was questionable. And we work with the carriers to receive replacement data. And we have begun to get replacement data in, well, everybody's working with us to replace data. But you can see if, let's start on the right side, submitting entities previously excluded because of data quality are, but they are now included. So we have, in the last database, and maybe the last two, we didn't have these, but now we do. And so whenever you make a request from this point forward, you'll be able to get these carriers. And the carriers that we're still working with are on the left. Humana is going to start resubmitting this summer, so hopefully in the fall we'll have all of that data again. Let's go to the next slide. So we have a new field on our member record that helps us pull the latest version of a member in their enrollment, in the records that make up their enrollment. And because if you have looked at the raw, if you've gotten data and you've looked at the raw claims, we get, the way the update process works, we get member records whenever a change occurs. And if you've got historical data, it can get really noisy. It gets very, very noisy. You know, which record do I use? Which one? And so we have added a field called version rank that will provide to you the record, the member record that you need to use that represents the current member enrollment. And you can still have some insight into how long they've been enrolled, and we can work with you on continuous enrollment, et cetera. So anyway, when you start to consider making a data request and you reach out to us to do so, we can talk you through this and figure out the best way to provide the member data, whether it be the latest and greatest or if you need all of the versions of the record that can get noisy. Anyway, we're here to work with you. And the link in this deck here will take you to the documentation about that. What is the next slide? We're probably close to the end, I think. Oh yes, so if you attended the last data user group, the one we had on campus real fast, oops. We talked about our data tips. One more. Okay. We have online data tips and data dictionaries, and I'm not going to even tempt fate by asking Kathy to click on these here because of the network issues we've been having. But do keep abreast. Do look at the data tips, especially because if we find something then that is weird, or we find a trick to selecting things like the information about using HIOS ID 32 and 36, that's in the data tips, then it can be a great resource for you when using the data, when you're actually touching the data. And some highlights that we've added here, I just, let's look at the first bullet, identifying test TPA member data for exclusion. So all of these, what all these numbers mean is that in you see the value, it says 99 EBD1. Well, that is a submitting entity ID that refers to the State Employee Benefits Division database. It's all the state employees and public school teachers. Well, they have a TPA, which is represented by 95442. And so that is a situation where sometimes we get some data from EBD itself, and then we get data from the TPA. And so that could create a duplicate. And you heard Nicole talk about that. And her example was with the claims data and the Medicaid data in Arkansas Works. So it's something to look out for, and because you want to be sure that the records that you're getting are as clean as possible. And if you have this, and if you have questions about this, don't hesitate to call us and ask us. We'll go through any data tip that you have questions about. There's a data tip about finding the birth year for Arkansas Medicare beneficiaries. If you have access to Medicare data, it is tough sometimes because we can't provide the PII, and it's tough sometimes to figure that out. So there's a tip in there on how to do it. Merge submitters and how to link their data. Sometimes submitters merge. WellCare and Windsor merged a few years back. And so there are tips in there on how to figure that out. And then identifying Medicare Advantage plans, which we talked about here. And so we will add all of these links to let's see, I'm reading a chat. We can add these links to the survey, and also we'll put this deck out on the Arkansas APCD website on the home page, so you'll have quick and easy access to it. So I'm looking at the chat real fast, and one question was, is the HIOS ID available to UAMS? Because UAMS has a subscription to the Arkansas APCD, and I believe it's out there. So I have noted who that's from, and we can answer. I'm pretty sure it's out there. And let's see. Were there any other? I think that's all of the questions that I have. Does anybody have any input? Have you experienced the collisions in the hash ID gender combination that Nicole described? Well, as you ponder, and if you do find them, again, don't hesitate to reach out to us. I said call us, but you can use our service desk, and that's on our website. And we can work through any of these questions with you. The data is big, the data is complicated, and without PII, it just adds a little nuance of complexity, but we have worked with it enough that we feel very confident that we can address it. All right, last chance for questions. No? Oh, okay. Again, I want to thank everybody for attending today, our Zoom meeting. And we are scheduling another data users group in July, I believe. The date will be on the survey. You will get a survey that asks you all sorts of questions about today. Look for the deck on our website. This is big data, and we have pains with it, and you do too, and we are here to help you. I appreciate your attendance today, and let's have a great day. Stay safe, everybody.